Welcome to another case presentation in the Refer Wisely campaign series. I am Raymond Russell, Associate Professor of Medicine at the Warren Alpert Medical School of Brown University and the incoming President of the American Society of Nuclear Cardiology for 2017. I will be discussing the application of appropriate use criteria to the preoperative evaluation of a 76-year-old man undergoing knee replacement. The patient is a 76-year-old man who was referred for preoperative cardiac evaluation prior to a right knee replacement. Over the past 6 months, his ability to walk has become severely limited due to knee pain, and therefore he seldom walks more than 1 block at a slow pace. He denies any chest pain, dyspnea on exertion, or orthopnea, although once again his level of activity is significantly limited because of his orthopedic problem. His past medical history is significant for the presence of hypertension, hyperlipidemia, chronic kidney disease, and type 2 diabetes mellitus. However, he has no history of coronary artery disease. His current medications include lisinopril, simvastatin, and insulin. On physical exam, his blood pressure is 126/84 and his heart rate is 80. He has no jugular venous distension and his lungs are clear to auscultation. Cardiac exam revealed a regular rate and rhythm and no murmurs were appreciated. He has intact distal pulses and no evidence of peripheral edema. The remainder of his exam is unremarkable. At this point, I would like to discuss some general concepts concerning preoperative cardiac risk assessment. Prior studies have demonstrated that the risk of perioperative myocardial infarction can be 1.4%, and the risk of cardiac death is 1% in a large cohort of patients. Furthermore, the risk of myocardial infarction and cardiac death increase in patients with specific risk factors that I will discuss later, as well as factors associated with the type of surgery. There are several important factors to consider in the preoperative evaluation of the patient. The first factor to consider is whether or not the surgery is emergent versus urgent or elective. The second factor to consider is whether or not a patient being considered for surgery is having an acute coronary syndrome. In this situation, the risk and benefit of both the surgical procedure and the concurrent acute coronary syndrome must be carefully considered. Third, the perioperative risk must be assessed based both on the functional capacity of the patient and the type of surgery. Finally, it is important to consider whether or not further testing will impact the overall treatment of the patient. The risk associated with particular surgical procedures can be categorized as low, intermediate, or high. Examples of procedures with a low surgical risk include breast biopsy, inguinal hernia repair, and arthroscopy. Surgical procedures with an inherent intermediate risk include hip or knee replacement, cholecystectomy, and major laparoscopic procedures. Surgical procedures with an inherently high risk include major orthopedic procedures, major vascular surgery as defined by a procedure involving the vascular system above the inguinal ligament, and major neurologic surgery. A very important patient variable that factors into the preoperative cardiac risk assessment is the functional capacity of the patient. Functional capacity can be expressed as the estimated oxygen consumption for various activities performed by the patient. Oxygen consumption under resting condition is defined as 1 MET, or metabolic equivalent. Previous studies have demonstrated that individuals who are unable to achieve at least 4 METs of work are at greater risk for perioperative cardiac events. Examples of the types of activities associated with 4 METs of exertion to include walking at 4 miles an hour on a level surface, climbing a flight of stairs, or performing strenuous housework. Taking all of these factors into account, the perioperative risk of a cardiac event can be evaluated using several different algorithms. One of the most commonly used is the Revised Cardiac Risk Index, or RCRI. The RCRI consists of 6 factors, each of which increase the risk of the perioperative cardiac events. These factors include high-risk surgical procedure, a history of ischemic heart disease, a history of heart failure, a history of stroke or TIA, the presence of diabetes treated with insulin, and a serum creatinine greater than 2.0 milligrams per deciliter. Using the RCRI, the risk of a cardiac event increases with the number of risk factors. Patients with none of the risk factors just discussed have a risk of a perioperative cardiac event of 0.4%. In contrast, patients with 3 or more risk factors have a perioperative cardiac event rate of 11%. Our patient has a history of both type 2 diabetes mellitus treated with insulin, as well as a serum creatinine that is greater than 2.0 milligrams per deciliter. Based on the RCRI, he has an estimated risk for a perioperative cardiac event of 6.6%. The 2013 multimodality appropriate use criteria for the detection and risk assessment of stable ischemic heart disease includes 7 different scenarios for preoperative risk assessment. The first scenario centers on patients with moderate to good functional capacity, that is the ability to achieve at least 4 METs, or the presence of no clinical risk factors. In this group of patients, the use of any of the non-invasive imaging modalities or invasive coronary angiography are rarely considered appropriate, regardless of the planned surgical procedure. Likewise, in the second scenario, in which the patient is asymptomatic and also has either a normal CT or invasive coronary angiogram, normal stress test, or revascularization within the prior year, the utilization of a preoperative cardiac testing is once again considered rarely appropriate for any type of surgery. However, it becomes more complicated if the patient has a poor or unknown functional capacity, that is, the inability to achieve 4 METs or greater. For this group of patients, it is important to understand both the inherent risk associated with the surgery as well as the patient-related clinical risk factors. Based on these factors, preoperative non-invasive testing can be appropriate, may be appropriate, or rarely appropriate. In addition, 2 procedures, kidney transplant and liver transplant, are considered special cases in which stress testing with radionuclide imaging or stress echocardiography are considered appropriate, while exercise electrocardiography, stress cardiac MR, and invasive coronary angiography may be appropriate. In the case of our patient, in whom we cannot assess functional capacity, he is to undergo an intermediate risk surgery and has 2 clinical risk factors that increase his risk for a perioperative cardiac event. Based on the AUC criteria, exercise electrocardiography, stress radionuclide imaging, stress echocardiography, and stress cardiac MR imaging all may be appropriate. However, in this scenario, calcium scoring, coronary CT angiography, and invasive coronary angiography are rarely appropriate. Because of his orthopedic issues, the patient was referred for a pharmacologic stress test with radionuclide imaging. He complained of shortness of breath during the infusion of vasodilator, a common side effect with the vasodilating agents. His blood pressure and heart rate did not change significantly during the stress test. The patient's electrocardiogram before the infusion of the vasodilator demonstrated sinus rhythm with a right bundle branch block. It is important to note that in contrast to left bundle branch block, it is still possible to identify ischemic electrocardiographic changes in the setting of a right bundle branch block. This electrocardiogram, obtained at peak vasodilator stress, demonstrates the presence of significant ST segment depression in leads V2 through V6, as indicated by the arrows. ST depression with vasodilator stress is a specific but not sensitive indicator of high-risk coronary artery disease. The stress and rest images from the patient's myocardial perfusion scan are shown on this slide. Although the goal of this presentation is not to teach individuals how to interpret perfusion scans, there are several abnormal high-risk findings present on the study that referring physicians should know about. The perfusion study shows a reversible defect present in the anteroseptal and inferior segments of the left ventricle. These findings are consistent with the presence of multi-vessel disease. In addition, the myocardial perfusion scans demonstrate the presence of transient left ventricular dilation. If you compare the stress images on the upper row to those from the rest images below, you can appreciate the larger left ventricular cavity size on the stress images. This finding is consistent with the presence of diffuse subendocardial ischemia seen with severe multivessel disease. In addition, the arrows call attention to the right ventricular free wall on the stress images that cannot be seen on the rest images. This finding of transient right ventricular visualization is also a high-risk finding, which is caused by an ischemia-mediated increase in the left ventricular and diastolic pressure, which in turn causes right ventricular strain. The patient's myocardial perfusion imaging had two other abnormal findings. The first was an increase in the lung-to-heart radio tracer activity. This is seen with an increase in the left ventricular and diastolic pressure and is generally caused by diffuse left ventricular ischemia. The second, transient left ventricular dysfunction, as evidenced by a decrease in the left ventricular ejection fraction from 50% to 26%, is also a high-risk finding, suggesting the presence of severe multivessel coronary artery disease and myocardial stunning. To summarize, the findings of the patient's stress test, he had ischemic electrocardiographic changes with pharmacologic vasodilation, an elevated lung-to-heart ratio, perfusion abnormalities in multiple vascular territories, transient right ventricular visualization, and transient left ventricular dysfunction. Once again, the intent of this discussion is not to train people to read perfusion studies. Rather, it is to make referring physicians aware of some of the factors that nuclear cardiologists consider high-risk findings on a perfusion study. Based on the findings of the stress test, the elective knee replacement surgery was canceled. The patient was referred for coronary angiography and was found to have 3-vessel coronary artery disease. He underwent coronary artery bypass grafting with an uncomplicated course. He then subsequently had his knee replacement surgery 3 months after his coronary artery bypass surgery. In summary, preoperative cardiac evaluation is based on patient characteristics, type of surgery, and urgency of surgery. Patients who are able to achieve at least 4 METs of physical activity without cardiac symptoms generally do not need further risk assessment. In addition, patients unable to achieve 4 METs of activity and have at least 1 risk factor may benefit from stress testing prior to their planned surgery. Thank you for your attention. I would now ask Dr. Andrea Medina for comments.
Thank you, Dr. Russell. Hi, I'm Andrea Parker Medina. I'm an assistant professor in the Department of Medicine, and I'm a general internist at the University of Oklahoma in Oklahoma City. I want to discuss this case from the perspective of a primary care provider and really emphasize again the need to understand your patient's perioperative cardiac risk. So this case for me really illustrates the importance of considering a patient's risk factors and thus their cardiac risk index before surgery. If you didn't do so in a case like this, you might be tempted to just say, sure, this patient goes straight to surgery. This is a non-emergent, innately low-risk surgery itself. Go ahead, go to surgery. But really you must determine the patient's own risk and not just consider the risk of the surgery alone. I also use the revised cardiac risk index score, and Dr. Russell really went over nicely the points of that. But just to reiterate, a score of 0 to 1 indicates a lower risk. A score of risk factors greater than 2, now the risk is increased of a cardiac event to 6.6%, and of course you see a risks 3 or more risks, then that almost nearly doubles. So it really requires further evaluation, and I think he went really nicely into the workup to further understand a patient's risk and any underlying heart disease or underlying increased risk for perioperative mortality and morbidity. Also, as was discussed in other cases that we've done about this preoperative risk, we really, as primary care physicians, we really can never clear somebody. We're often asked to clear. And that's not something we really can do, but we can help assess the risk. And this is one of the most important things that we do for our patients. So I would encourage you to, again, familiarize yourself, if you haven't, with that revised cardiac risk index and understand the indications for moving forward with further cardiac evaluation. Thank you very much.
Dr. Medina, thank you so much. I cannot agree with you more that what our role is to provide preoperative cardiac risk assessment, not clearance for the patient. It is so important to identify what the risk is and what steps we can take to mitigate that risk, be it through further preoperative testing or optimization of their medical therapy or revascularization prior to the therapy.